Imagine you get paged to the ER at 2 a.m.
Yeah, we've all been there.
Right. A patient rolls in with a mangled hand from, say, an industrial press. And your immediate instinct, especially early on, is to hyper-focus on just saving the digits.
Which is a totally natural reaction, but it's a trap.
Exactly, because if you dive in without fundamentally understanding the biomechanics of the carpal rows or the static restraints of the metacarpophalangeal joints, you're going to leave that patient with a beautifully reconstructed, totally frozen claw.
Oh, absolutely. It's an unforgiving area to operate on.
So today we are taking a deep dive into upper extremity functional anatomy, acute trauma management, and operative principles. The mission here is a high-yield run-through to keep you sharp in the ER and the OR.
Because the tolerances in the hand are basically zero. The anatomy is compact, and the interplay between moving parts is, well, it's highly complex. If you ignore the physics, your repair will fail.
It's a tightrope walk, right? Balancing immobilization for healing with immediate motion to prevent stiffness.
It's the defining struggle of hand surgery, yeah.
Mechanics dictate outcomes every single time. And we see this immediately when we look at the digits. The whole system is an exercise in balancing mobility with stability, starting right at the thumb.
Right. The thumb is highly specialized, but its two main joints have completely opposing jobs.
The carpometacarpal joint and the metacarpophalangeal joint.
Exactly. The thumb CMC joint is the master of mobility. I mean, it needs a massive arc of motion just to position the thumb in space for opposition.
But move one joint distal right to the MCP, and the biological priority completely flips.
It flips to pure stability. If you have laxity at the thumb MCP joint, like a compromised ulnar collateral ligament, you completely lose the ability to pinch.
The joint just collapses backward.
Right. Now, when you look at the other digits, index to small finger, the CMC joints have a totally different pattern. There's this distinct gradient of mobility that increases dramatically as you move toward the ulnar side.
Which is a huge clinical pearl for anyone setting fractures.
Oh, massive. The index and long finger CMC joints are essentially rigid. They form the stable central pillar of the hand. But the ring and small fingers have significant volar and dorsal give.
And that ulnar mobility is exactly why angulated fractures, like a classic boxer's fracture of the fifth metacarpal neck, are so much better tolerated in the ulnar digits.
Because the ulnar CMC joints have enough compensatory motion to make up for the bony angulation. You just don't have that luxury on the radial side.
Right. If you leave a 30-degree angulated fracture in the index finger, that patient is going to have a severe grip deficit.
And they will be right back in your clinic complaining. The central pillar simply cannot compensate.
So let's move distally down the fingers. I like to think of the hand like a heavy vault door. The MCP joints are the main hinges on the frame, right?
That's a great analogy.
And the PIP and DIP joints are just the locking mechanisms further down. If the main hinges are fused shut, it absolutely does not matter how well the locks work. The door isn't opening.
It's the perfect way to visualize it. The entire arc of motion for the fingers initiates right at those MCP joints.
You have a little more tolerance for stiffness in the PIP, right?
A little, yeah. And especially the DIP joints. In those terminal joints, stability actually trumps mobility when you're making a tight fist. But if the MCP is stiff, the finger is basically useless.
So if you don't secure those joints properly, you get a massive functional deficit. And the absolute least forgiving deficit, bar none, is rotational deformity.
Zero tolerance. Zero.
Because of scissoring.
Exactly. The flexor tendons naturally pull the fingers in toward the scaphoid tubercle. If a digit heals with even just a few degrees of rotational malalignment, when they make a fist, that finger crosses over and blocks the normal finger next to it.
Or constantly catches on their pockets. It's an incredibly frustrating, visually obvious deficit.
And preventing that means understanding the forces across these joints. You have dynamic compression for the tendons, but also the static constraints, the collateral ligaments, the joint capsules, and the volar plates.
Let's dig into the volar plate. Say you're standing in the ER at 2 a.m., you're trying to reduce a dorsal MCP dislocation, and the deformity suddenly gets worse while you pull traction.
Your instinct is to pull harder.
Right.
Don't stop immediately. If it looks worse during closed reduction, the volar plate is likely interposed right into the joint space.
The traction actually tightens the tissue around the metacarpal head.
Like a Chinese finger trap.
Yeah.
You are not going to get that reduced closed. Do not force it. That is an immediate trip to the OR for open reduction.
And that volar plate pathology creates a cascading disaster further down the finger, too. If there's a dorsal dislocation of the PIP joint, the volar plate tears.
Right.
And in the OR, if you don't anticipate what happens next, you're going to miss the impending swan-neck deformity.
Because you have to think about what the volar plate actually does. It's a static restraint against hyperextension. When it's torn, the PIP joint chronically hyperextends.
Which alters the tension on the extensor mechanism.
Exactly. The lateral bands subluxate dorsally above the axis of rotation. So the finger gets locked with PIP hyperextension and DIP flexion.
Which is the exact opposite of a boutonniere deformity.
Right, because with a boutonniere, the mechanical failure happens dorsally. The central slip insertion on the middle phalanx is disrupted. Without that holding things up, the lateral bands subluxate volarly.
They drop below the axis.
Yep. So the PIP is forced into flexion, and the DIP gets pulled into rigid hyperextension.
Okay, so the digits are completely unforgiving.
Yeah.
But they're also totally useless if their foundation is unstable. Which brings us to the wrist.
Where the biomechanical complexity just multiplies exponentially.
8 carpal bones, 2 rows. Normal flexion extension is 90/70 degrees. But functionally, an 80-degree arc gives a patient a very usable hand.
Yeah, functionally, rotation is the real issue. Patients can tolerate a loss of hand pronation surprisingly well, as long as they have a good shoulder to internally rotate.
But loss of supination is a nightmare.
You can't easily compensate with the shoulder to hold a bowl of soup or, comfortably read your phone.
So let's talk stability at the wrist. The distal radial manar joint is a major pitfall. The ulna doesn't even directly contact the carpal bones.
Right, it connects to the radius through the TFCC. 80% of the axial load goes directly through the radiocarpal articulation.
Which relies heavily on those incredibly tough volar capsular ligaments.
Here is a massive key point for the OR. When you're doing an ORF for a distal radius fracture, you might be tempted to incise those volar capsular ligaments to see the articular surface.
Do not do it.
Do not do it. It can lead to massive, irreparable radiocarpal instability. You use fluoroscopy or arthroscopy to check your joint surface, not a scalpel.
Preserve the volar capsule at all costs. Now, the carpal rows themselves are this crazy masterclass in tension. Look at the lunate. It's an intercoltelated segment sandwiched between the scaphoid and the trichotrum.
And it has no major tendon attachments driving it. It just passively follows whatever bone it's strongly attached to.
That tug of war is how you recognize carpal instability on an X-ray, right?
Exactly. Normally, the scaphoid inherently wants to flex volarly. The trichotrum wants to extend dorsally. The ligaments balance them out so the lunate sits perfectly neutral.
But if the scapholunate ligament is torn,
that link breaks. The scaphoid flexes forward unrestrained, and the lunate is left attached only to the trichotrum, which pulls it backward into extension.
the lunate tilts dorsally.
Right. That's your classic dorsal intercalated segment instability, or DISI.
And if the injury is on the other side, a lunotriquetral disruption, the reverse happens. The unrestrained scaphoid pulls the lunate forward into severe flexion,
resulting in volar intercalated segment instability, or VISI.
So all of these intricate mechanics are exactly what shatter when the patient actually rolls into the ER with acute trauma.
Right. And when you walk into the trauma bay and see a mangled hand, it's dramatic. It's bleeding everywhere. It looks chaotic.
It draws every eye in the room. But you have to run your sequence, life over limb. You have to rule out life-threatening injuries first.
And when you finally address the hand, never, ever blindly clamp a bleeding vessel in the ER.
There are just too many critical nerves right next to the arteries.
If you throw a hemostat into a bloody field, you will crush the median or ulnar nerve. You control hemorrhage with strict elevation and direct sustained pressure.
Okay, let's talk real life, though. ERs love to inflate a blood pressure cuff on the upper arm to stop the bleeding while they wait for us.
They do.
What's our actual deadline before that causes irreversible damage?
90 minutes is the absolute maximum in the ER. Beyond that, you're inviting devastating ischemic reperfusion injury.
The tissues start rapidly dumping toxic metabolic byproducts.
Exactly.
Wait, I have to push back on that 90-minute rule for a second. In a complex digit replant in the OR, you are easily going to pass that time limit. What's a physiological line where you decide to let the tourniquet down?
In the OR, you might push it to 120 minutes max if you are literally minutes away from critical fixation.
Yeah.
But the risk is systemic.
When you release it, all that lactic acid floods the system.
Potassium, lactic acid, all of it. It causes massive tissue edema, endothelial damage, even systemic arrhythmias. If you hit 120 You drop the tourniquet, pack the wound, and let the arm perfuse for 15 to 20 minutes before inflating again.
And that ischemia clock is exactly why we strictly prioritize hypothermia for amputated digits. Wrap it in moist gauze, put it in a plastic bag, and put that bag on ice.
The cold drastically reduces the metabolic rate, extending your viability window.
You also have to watch out for pressure injection injuries. A guy comes in after shooting his finger with a paint sprayer or grease gun.
The entry wound usually looks like a tiny pinprick
They look innocent, but they are limb-threatening emergencies.
because the pressure drives that fluid deep, and it dissects right along the flexor tendon sheaths. Caustic materials like paint or solvents cause massive rapid necrosis.
If you don't aggressively open and debride that entire sheath in the OR immediately, they lose the digit.
Absolutely. Now, when you're evaluating any of these traumas, your physical exam needs surgeon-level detail. Use a handheld Doppler for the digital arteries.
And remember the arterial dominance. The ulnar artery provides most of the blood flow via the superficial palmar arch.
But the radial artery supplies the thumb and index finger
Hmm.
through the deep palmar arch, the princeps pollicis.
Which is why the Allen test is absolutely mandatory before any arterial intervention at the wrist.
You have to assess if the ulnar artery can perfuse the whole hand if the radial is injured. You occlude both arteries, have the patient make a tight fist until the palm blanches, then release only the ulnar artery.
And watch for the flush. Color should return aggressively within 5 seconds.
Right. And for nerve injuries in a chaotic trauma bay, don't waste time mapping overlapping dermatomes. Use the autonomous sensory zones.
Zero anatomical overlap.
Exactly. Radial nerve is the first dorsal web space. Median nerve is the volar index tip. Ulnar nerve is the volar small fingertip.
For finger lacerations, you need to test 2-point discrimination distal to the injury. Here's a real-life pearl. Take a standard paperclip and bend it so the tips are exactly 5 millimeters apart.
It's the perfect standardized tool for the ER bay. Way better than guessing with forceps.
Okay, so you've mapped the deficits. Now you need imaging, splinting, and a pre-op plan. Let's start with radiographs.
A single-digit injury needs a true AP and a true lateral of that specific finger.
And the key word is true lateral. The condyles of the phalanx must be perfectly superimposed with absolutely no overlapping bone from adjacent fingers.
You can't see the joint space, send them back to radiology. And remember, the thumb sits in a rotated plane, so it needs its own specific oblique views.
Once you have the images, you have to communicate the injury to the team, which brings up a pet peeve. Why do hand surgeons absolutely hate the term collis fracture?
Because eponyms are completely useless for operative planning. Saying collis fracture just tells the OR the patient broke their wrist. It gives zero actionable information.
You have to describe fractures anatomically. Bone, location, intra-articular extension, apex angulation, pattern, comminution, and displacement.
Exactly. Think about the difference. Compare the eponym to saying an apex volar intra-articular distal radius fracture with severe dorsal comminution, 30 degrees of dorsal tilt, and radial shortening.
With that description, you immediately know what plates and screws to ask the scrub tech for.
Before you even step foot in the room.
So, you have the images, you know the plan, now you have to immobilize the extremity temporarily.
Which brings us back to the war between healing and stiffness. The gold standard for splinting is the intrinsic plus position.
Our primary weapon against stiffness. Wrist in slight extension, MCP joints in near full flexion like 70 to 90 degrees, and IPs in full extension.
The mechanics there are brilliant. The metacarpal head is shaped like a cam. It's wider volarly, so when you flex the MCP joint, the collateral ligaments are stretched to their maximal length.
If you splint the MCP joints in extension, those ligaments are lax, they scar down short, and the patient never makes a full fist again.
For the splints themselves, avoid circumferential casts acutely because of swelling. A sugar tongue splint is great for the distal forearm. It controls flexion extension and pronation supination.
And for metacarpal fractures, an ulnar gutter splint. It immobilizes the ulnar side, but leaves the thumb and radial digits free for early rehab.
Right. So you've splinted the patient, booked the room. Let's talk operative principles.
Starting with anesthesia.
Local blocks, like a wallet technique or regional blocks with mild sedation, are fantastic for routine cases.
But there's a huge trap here with severe trauma. Regional anesthesia, like a long-acting interscalene block, is great for pain control. But if there's any risk of compartment syndrome, like a crush injury, it's incredibly dangerous.
Because it completely masks ischemic pain. The patient won't feel the compartment pressures rising.
You lose your most sensitive clinical warning sign. pain out of proportion to the injury.
Always avoid long-acting blocks if you need to monitor compartments.
Let's talk tourniquets. Upper arm tourniquet is set to 100 millimeters of mercury above systolic pressure. But what if you're using a local finger tourniquet in the ER?
Here is the golden rule. Always clamp a large hemostat to it.
Because the patient usually has a digital block and can't feel the ischemia.
Exactly. If you roll a surgical glove finger onto the digit to control bleeding and accidentally leave it under a bulky dressing, they will lose the finger. Clamp a heavy instrument to it so you physically cannot miss it.
Regarding incisions, the biomechanical rules are totally rigid. Never cut straight across a flexion crease.
The scar will contract and permanently limit extension. On the dorsal hand, the skin is highly mobile, so straight longitudinal incisions are fine.
But on the volar surface, use zigzag incisions like the Bruner incisions.
Those diagonal cuts create broad-based flaps that prevent linear scar contracture. If a traumatic laceration already crosses a crease, you strongly consider a Z-plasty during closure.
Okay, surgery goes perfectly, incisions are closed. What happens in post-op? It feels like everyone argues constantly about post-op antibiotics for elective cases.
Yeah, but the data is clear. For routine elective soft tissue procedures, carpal tunnel, trigger fingers under 2 hours, there is no clear benefit to post-op oral antibiotics.
The risks of resistance and GI issues outweigh the benefits.
Right, but open fractures or major bony work with hardware, that warrants 24 hours of IV coverage.
Antibiotics aside, what's the single most critical post-op instruction?
Elevation. You literally cannot overemphasize this.
It sounds so basic, but it's the difference between a smooth recovery and a nightmare. Swelling causes pain, wound breakdown, and crippling stiffness by gluing the tissue planes together.
Keeping the hand elevated, fingers to the sky, drastically shortens recovery times.
It minimizes edema so the tendons can glide during rehab.
Exactly.
All right, let's lock in the non-negotiables. Respect the MCP joints. They're the main hinges. Splint them in flexion.
Kill the eponyms. Describe fractures anatomically.
Watch your tourniquet clock like a hawk. Keep it under 120. And preach elevation until you are blue in the face.
Those are the fundamental laws of upper extremity surgery.
So I want to leave you with a final clinical thought to chew on. Hand surgery is a constant, delicate war between immobilization to allow fragile tissues to heal and immediate motion to prevent scar tissue. Think about how your individual surgical precision, the exact rigidity of your bony fixation, the meticulousness of your tendon repair directly dictates which side of that war wins. The stronger your repair, the earlier they move. Keep your skills sharp.